Thank you for joining us today. My name is Elaine Sigler. I'm in Provider Outreach and Education. Also on the line with me is Mary Sue Gardner. We're co-presenting today, so you're going to hear from both of us, and you'll hear from Mary Sue a little bit later. And what we're here is to explore the critical impact of accurate discharge status codes or discharge status disposition codes on Medicare claims. If you want to download a copy of this slide deck that we're using today, you don't have to have it in order to participate, but if you'd like to have a copy, you can find it on our website in the Training Center. You'll find the Training Center up at the top of the screen. You'll be able to download that. Now, once the webinar is over, either later today or tomorrow, that will come down. So if you want it, you'll need to get it pretty soon after the webinar is over if you haven't done that already. The Training Center of our websites where we post event materials like this, and we do that about a week in advance. And it's on the live events page, and that's the link that Mary Sue put in the chat for you. This is also where you know about webinars that we're hosting and register for them. Probably that's where you went to register for this, but we do have new people who maybe were forwarded the link or found it some other way. And so just so you know, that's where you're going to find a whole list of everything that we have upcoming. And we do a lot of webinars on any given day. The recording of this and other live webinars will be on our website. There's another page, it's called our Encore Presentations. So if you missed an event, it didn't fit into your schedule, maybe you want to listen to it again or you want to share it with people that you work with. We have a number of events out there at any given time. They normally are available for 60 to 90 days, but because of the volume of education that we do, they kind of rotate on and rotate off. You can also find them on our YouTube channel. That's a good place to go, but we realize that not everyone can go to YouTube during work hours or on their work computer for various reasons. And so while they're in our Encore presentations on our website, we do have a player embedded there where you can watch them without going to YouTube. So trying to get the education out in multiple different ways to reach the most people that we can. You're going to use the chat feature today to add any questions that you have related to today's topic. And then at the end of our prepared remarks, we'll check in with you and we'll take as many questions as time allows. Whether you're listening live or you're listening to this as the encore, we hope that you'll take the opportunity to give us your feedback by taking a survey. We offer a survey after every event because we're looking for insight into not only how we're doing, but the types of education that you want and you need. A couple more items of housekeeping. This disclaimer lets you know that the information that we're providing is as accurate and complete as it can be. Medicare does change. It's a federal program. And so as those federal regulations change, they'll take priority over anything that we're presenting today or that we happen to have in our resources. And then finally, CMS does prohibit the recording of this presentation for profit-making purposes. We're giving you the slides. We're recording this for you, so there really would be no need for you to do that, especially you can't do that if you're going to be sharing it with other people at a cost. Here we have a couple copyright notices. This one's for the current procedural terminology for the American Medical Association. And then we also have this one for the American Hospital Association and the National Uniform Billing Committee. These are their copyright notices. They let you know that WPS does not create, own, or maintain the codes within this presentation. Next two slides contain acronyms. Medicare is full of acronyms, and these are ones that were specifically used in the creation of this presentation. We want to make sure that we give you a list to look back at, to reference, in case some of these acronyms are not ones that you're familiar with, that you haven't come across that often. Since there are so many, it just helps us all to have them in one place, but they are sprinkled throughout the presentation as well. Our goal for this education is to improve accuracy and compliance with Medicare guidelines. We also want to gain an understanding of how to prevent delays and denials. We'll accomplish this by defining discharge status codes. We'll be reviewing Medicare's transfer policy, explaining the importance of accurate coding, discussing how errors may happen, and then we'll round out our time together today by looking at some example situations from recent reviews. We begin by defining some key terms related to our discussion today. And we start with prospective payment system, PPS. In general terms, a prospective payment system, or PPS, is a method of reimbursement in which Medicare payment is made based on a predetermined fixed base rate for a given unit of service. This given unit of service could be per day, per stay, per procedure, or per episode of care. The base rate comes from a classification system of that service, and then the payment is adjusted based on certain other factors, geographical location of the facility or the provider, clinical severity, being a teaching facility, or even based on quality of care. CMS uses separate prospective payment systems for reimbursement to many different provider types. Among them are acute inpatient hospitals, home health agencies, hospice providers, acute hospital outpatient, home health agencies, I already said that, sorry. I'm trying to think of other ones. Inpatient psychiatric facilities, inpatient rehabilitation facilities, long-term care hospitals, skilled nursing facilities. So more and more facility types are paid based on a prospective payment system. Not the same prospective payment system, but again, just explaining it in general terms, that is what we're doing here. Then the reimbursement depends on that, like I said, that predetermined payment, and that's regardless of the intensity of services that are provided. If we want to go back to the section of the Social Security Act, it's 1886D, that's where the law states that a system of payment for operating costs of inpatient acute care hospital stays under Medicare Part A is based on a prospectively set rate, and it names the Inpatient Prospective Payment System, or IPPS. See, I wasn't kidding when I said there were a lot of acronyms. We've used several already. So as I stated, Medicare bases payment on codes using the classification system for that service, such as diagnosis-related groups for hospital inpatient services, or ambulatory payment classification, APC, for outpatient hospital services. The amounts are, with certain exceptions, payment in full to that hospital for inpatient operating costs. Under IPPS, each case is categorized into diagnosis-related groups, or DRGs. So that's the next term that we're going to define. The categorization of medical and surgical services into DRGs is a key part of IPPS. And some of you may already be well versed in this, but in looking over the registration list of people who signed up for this course, several of you did state that you're new to this concept or new to Medicare and you're just trying to learn everything that you can. And so going back to the basics, and breaking this down, we felt was very helpful. So each DRG has a payment weight assigned to it. It's based on the average resources or services used to treat Medicare patients in that DRG. The DRGs bundle services that are needed to treat a patient with a specific or particular disease. Then CMS creates a rate of payment based on the average cost to deliver care to a patient with that particular disease. Hospitals receive a predetermined rate per discharge based on the severity of the illness, and no matter how many days the patient stayed or how many services they used, Medicare would pay the same base or standardized amount for the same DRG code. Now, it's not as simple as that. There are a lot of unknowns. There are a lot of different things that could, searching for words, adjust or make an impact on the final payment. But again, we're giving you high level, in a nutshell, kind of in general terms, what these are. Now, the next one that we want to define for you is grouper software. And the grouper software is one of the computer programs that's used to support this prospective payment system. It gathers claim information and it groups all discharge into one of the major diagnostic categories, or MDCs. An MDC is a broad grouping of medical diagnoses that share similar characteristics, and they're often based on the affected body system or a specific medical condition. They're used as the first level of classification in the Medicare Severity Diagnosis Related Groups, or MSDRGs. And those are used to categorize hospital inpatient stays for payment purposes. So we start with these broad categories and then we get more specific. After that, the grouper software assigns the DRG number from data elements that are reported by the hospital, and it's the things like you see here. We have principal and other diagnoses, principal and additional procedures, the patient's age as of their last birthday at the time of admission, the sex or gender of the patient, and the discharge destination, also known as the patient status code, which is what we're kind of focusing on here today. Now, this is just a little bit of a side note, and I just thought of this, but for your information, the grouper software doesn't determine the DRG price or payment. That's done by a different companion software called the Pricer. Sometimes when you hear conversation or you've attended other education, grouper Pricer is kind of used together. And they are, like I said, companions. They work together. Grouper assigns the DRG, Pricer assigns the price. So now start line and distinguish between transfers and discharges. If you're new to Medicare, these things might seem the same. The patient's leaving, the patient's leaving. Why does it matter? Well, it does matter. And so we want to give you CMS's definition, Medicare's definition. So in the context of Medicare, a transfer refers to the movement of a patient from one healthcare facility to another. Specifically, when a patient is moved from one acute care hospital or unit to another for further treatment, or when a patient leaves a Medicare participating hospital and is admitted to another type of healthcare facility, like a skilled nursing facility, on the same day. This can also include situations where a patient is moved to a facility excluded from IPPS. So a transfer occurs when a patient moves from one healthcare facility to another, or within the same facility to a different level of care, or from one department to another. A transfer is distinct from a discharge. In a transfer, the patient moves to another facility for continued care, whereas a discharge usually signifies that the patient is leaving the healthcare system entirely. So let's define discharge next. A discharge typically signifies a patient's formal release from a healthcare facility, either when they are deemed no longer needing medical services or when Medicare stops covering those services. The most straightforward definition is when the patient leaves the hospital after receiving complete care. They came to the hospital, they got the care they needed, or the services or the procedures that they needed, and now they're done. They're well, they're leaving. A discharge might also be the end of coverage. In some cases, a discharge can occur when Medicare benefits for the current stay are exhausted, even if the patient hasn't physically left the hospital. It may be a discontinuation of services. Medicare might determine that they will no longer pay for the patient's services, leading to a discharge, or a physician and a hospital determine that the patient no longer requires medical services. A leave of absence from the hospital can be treated as a discharge if the patient doesn't return. A patient is also considered discharged when he or she dies in a hospital. The date of death then is the discharge date. So we wanted to take a little time to define each one of those and talk about how they're different, because it does matter. The last term we're going to define today, before we move on, is discharge status code. These are 2-digit codes that are entered in field or form locator 17 on the UB04 claim form, or its electronic equivalent. They specify the patient's destination upon leaving the facility or those other instances that we just talked about. So they indicate where that patient is being discharged to at the end of a stay or at the end of the billing cycle. And we'll review some examples in just a few minutes. Transfer policies that Medicare has in place, or CMS has in place, also address payment implications, such as how sending and receiving facilities are paid. For example, some transfers trigger DRG payment adjustments, and by payment adjustments, I mean something out of the ordinary for the standard payment for a particular DRG. They also address the management of readmissions, including those that are to different types of facilities or units. The Medicare acute care transfer policy applies to cases where the patient is readmitted the same day to a hospital that is paid under IPPS. And for transfers between IPPS hospitals, the transferring hospital is paid based upon a per diem or daily rate. The payment to the final discharging hospital is made at the full prospective payment rate. This also applies to transfers to a hospital ordinarily paid under IPPS, but for some reason is excluded or does not have a Medicare agreement in place. It could also apply to a critical access hospital. For those of you who might not be in an area where there are many critical access hospitals, those are typically smaller rural hospitals who have been granted critical access status by CMS. For transfers from an IPPS hospital to a hospital or unit excluded from IPPS with a DRG that's not subject to the post-acute care transfer policy, and I know we haven't talked about that yet, the transferring hospital is paid the full IPPS rate. The payment to the final discharging hospital or unit is going to be made at the rate of its quote unquote normal or regular respective payment system, depending on the type of facility that it is and how that facility type is paid. The Medicare post-acute care transfer policy dictates that when a patient is grouped to a certain MSDRG, discharged from an acute care hospital and transferred to a post-acute care setting like a skilled nursing facility, inpatient rehab, or long-term care, let's say, the hospital may not receive the full DRG payment. Instead, the hospital may receive a daily or per diem payment. It may also pertain when the patient is discharged to home under a written plan of care for home health services from a home health agency, and those services occur within 3 days after the date of discharge. So I know that's a lot to take in, especially for those of you who are hearing these things for the first time, but we're building on your education here. And even those of you that deal with this or have been dealing with this and know about this for a long time, I think there's little pieces and parts in here that are going to help you understand even more and put those pieces together as you go along. So now we want to talk about the importance of the status codes. It's just 2 little digits. Why does it matter? Why does it matter so much and enough that we felt that this education was necessary? Well, by the time we're done today, you will see why it is so important. Now, this slide contains just a few of the more commonly used discharge status codes. Obviously, it's not an all-inclusive list. There is a whole bunch, and some of them aren't used by Medicare. But these are created and maintained by the National Uniform Billing Committee, and they're for all healthcare payers, not just Medicare. So what I've done is Mary Sue and I just pulled out a few that you might see and use on a regular basis as examples for you. 01, discharge to home or self-care. 02, discharged or transferred to a short-term general hospital for inpatient care. 03, discharged to a skilled nursing facility with Medicare certification. We did receive a question that was submitted ahead of time, and I'd like to address that now. And the question said, if a patient is a resident of a skilled nursing facility prior to admission to the acute care hospital, and the patient returns to that same skilled nursing facility after discharge, is the correct discharge disposition status 01 home, since the SNF is where the patient lives? And I want to thank you for sending this question in, because probably more than one person has the same question. But the answer is no. The discharge status code would be probably 03 in this situation, because that is how the facility, and I'm talking about the skilled nursing facility, is classified and paid by Medicare. We got another question that kind of is along the same lines here, and they asked if they asked about the discharge to a skilled nursing facility or assisted living. Now, if this same situation that came in on our question was that the patient came from assisted living and went back to assisted living. Assisted living isn't reimbursed by Medicare. So in essence, that's an apartment. So that would be the patient's home. So I hope that helps clear that up for the two people that submitted those questions. And again, I want to thank you for sending those in. Where were we? Okay, 06, that's another one that you might see. That's discharge to home under the care of an organized home health service organization with a written plan of care. So the 06 is going to come up probably multiple times for you, and I know that we have some more discussion about it coming up later in our presentation. 20, status code 20, the patient has expired or died. 30, still a patient. This code is used for interim billing for certain facility types or to indicate that the patient is still receiving care at the end of the billing cycle. So just some examples for you there. Using the correct code is vital for proper billing, claims processing, and to avoid claim denials or recoupments. We usually think of Medicare and CMS as only frowning upon overpayments, looking to get money that Medicare paid in error back to the Medicare program. But it's important to know that an underpayment is still an improper payment, and it is still counted as an error. Another implication of an incorrect discharge status is continuity in keeping the patient's benefit period up to date. Not only does it cause time and headache to change it after the fact by adjusting the claim, which, don't get me wrong, if you find out that your discharge status code is incorrect, you do need to do an adjustment and correct it. But when you do that, it's a debit credit adjustment. So any money that you originally got from Medicare is returned. The claim is put back into a status of suspense, so it's pending again. Any days that the patient used on your claim is put back into their benefit period or their bucket of days to use. And in the interim, another facility's claim could come in and process and take those days, whether they were full days, coinsurance, lifetime reserve days, and you're left with a benefits exhaust situation. And that's because claims are paid or processed on a first in, first out basis. And so we want to avoid that rework, just the time and the effort that it takes. But also it's another implication because it can affect their benefit period. It can be viewed by abuse. Actually, in the past, we've had facilities that said it takes too much time to go through the notes and figure out where the patient went. So we just put 01 on all of them or 03 on all of them, knowing that the system has edits, or even the common working file will send us a notice if another claim comes in on the same day or a home health claim comes in within 3 days, and we just fix it after that. This can actually be looked at as abuse if it continually happens, because it does cause more work, therefore more money coming out of the Medicare Trust Fund. It can cause the beneficiary to owe money when they shouldn't have, or it can hold up claims processing and benefits for future stays from other facilities. So we want to do it right the first time to the best of our ability. I already mentioned that days originally paid to you could be taken by another facility when those claims come in and while your adjustment is processing. We talked about how payments are calculated differently for transfers as opposed to discharges. So this is also important and a very important step in determining the appropriate DRG and therefore payment. So just want to make sure that we're clear on all of that. It really does matter, and it really is important. This time I'm going to turn the microphone over to my friend and colleague for the remainder of the presentation. So Mary Sue, please go ahead.
Thanks, Aline. Well, hello, everyone. Welcome again to today's event. I want to tag on to the information that Aline just provided you and give you information from more of a clinical perspective on how to help making sure you're choosing the correct discharge status code and reporting those in your documentation. So we're going to start with identifying which code to choose at discharge. So moving on to our next slide, let's talk about how we do that. And on the next slide, we'll talk, here we are, about documentation. So if you're a biller or a coder and you're trying to identify which code to use, you should be using the information that is based in the documentation in the discharge summary. So the information that is included in your documentation at the time of discharge. And again, generally that appears in your discharge summary. So as a provider, you're responsible for coding the discharge bill based on that discharge plan for that patient. And then if you later learn that the patient receives some other type of post-acute care, the hospital, like Aline said, should submit an adjustment bill to correct the discharge status code. And they should follow the information that's in the internet-only manuals. And I'm just going to put those manuals into the chat just as a reference for you. Now, we understand that verification can sometimes be difficult because the summaries may be incomplete or something unexpected happened with your patient. Examples like those included are here on your slide, just a list of them to kind of name a few. So maybe arrangements were made for the patient to go to home health care after discharge. However, home health, that care may not have started until day 4, which means that's outside that window. And Aline kind of talked about, home health being captured within those 3 days. And if it is, then you have to report the correct discharge status code for home health. So therefore, if they did end up going to home health and it was outside that window, perhaps that's a situation where you just didn't know. You thought home health was going to be in there within those first 3 days. They were not. It wasn't until after day 4. And then, so in essence, the discharge status code is wrong. And we're going to talk about some of those situations again coming up here and some examples and go over some practical tips of how to avoid these. Other issues, paperwork is completed, signed, dated. So everything that you have on file, all your documentation seems to be right in line with where the patient is going after discharge. And then at the last minute, the family decides to take the patient somewhere else, other than where the arrangements were supposed to be. Maybe they were supposed to go to a SNF and the family just took them home, or vice versa. So those are, another example of how this could happen. And, based on the documentation that you have at hand, everything looked correct. And then finally, just remember, incorrect coding could affect payment under that post-acute care transfer policy. So this could affect not only the discharging facility, but also the receiving facility. So on the next slide, we're going to move on, and we're going to talk about how discharge status code errors happen. So I want to review some of the most common errors. On the documentation slide, we reviewed some of these, but on the next slide, let's talk a little more in depth. So the first one is the patient goes somewhere else. This is probably one of the most common reasons an error happens on reporting the discharge status code. So as we mentioned before, it could be that the patient was supposed to go to one place and didn't, or the patient was supposed to start a home health episode of care after discharge, but that didn't start timely. The documentation in these cases may or may not have been correct. So if the patient left and everything appeared as it was supposed to, then the documentation at the time of discharge was in essence correct. However, if the patient is still in the hospital and the documentation shows that they, let's say, are going home, but instead, right before they leave, the family decides that they want to go to a skilled nursing facility instead. They think, oh my God, you know, I'm packing mom up in the wheelchair and doing all this stuff. We're not going to be able to care for her at home. And so they decide at the last minute, after all your discharge paperwork is done or appeared to be done, that they're going to go somewhere else. In cases like this, then your documentation needs to be updated to reflect the correct discharge disposition. So later, we're going to talk about some practical tips and how to, how to do this and how to avoid this being an error. So on the next slide, the next error that I want to talk about is a miskeyed claim or fat-fingered claim. So this is this next most common reason. It's simply just coded incorrectly by the coder. And again, like I said, this could be as simple as a slip of the finger or what we call fat fingering a key. Generally, this is an honest mistake. The documentation may have listed the discharge disposition correctly. For example, like an O2, which is a discharge or transferred to a short-term general hospital for inpatient care, was keyed, or was supposed to be keyed, but instead the biller hit the 5 instead of the 2. So the O5 is discharged or transferred to a designated cancer center or children's hospital. That could be an easy miskey on a 10-key number pad because, that 5 is right above the 2. I'm sure I'm not the only one that miskeys things, quite frequently, especially when I'm typing fast. So it's an honest mistake. It's a fixable mistake. And we need to, before we hit that F button to submit that bill, we need to make sure that all the information that is appearing on the screen is correct and correct based on the documentation you have in front of you. So moving on to the next slide. The next issue, and we've talked about this as well, but I just want to reiterate. So a delay in home health services. If you're coding a discharge with a discharge status code of 06, home, under a home health care organization or under a home health care service, and you're anticipating that the patient is going to be receiving covered skilled care, and something happens and that care does not start in those 3 days of discharge, even if the documentation was correct that it was supposed to happen, the discharge status code may end up being incorrect in this case. So, and again, after we go through some examples and stuff, we'll talk about some practical tips and how you could potentially avoid some of these things in the future. So let's move on to the next slide. And we're going to talk about some examples that have come up in recent CERT reviews and errors that are associated with discharge status codes. So moving on to the next slide. Our first example, and this actually comes out of our Jurisdiction 5 contract of work. But in the example, per the CERT medical reviewer, or the comprehensive error rate testing, that medical review program for the federal government, the discharge disposition that was listed was 04, which is an intermediate care facility. That's what was coded by the facility. It should be the 03, the skilled nursing facility. So after the CERT contractor reviewed the submitted medical records, and then they also looked at the common working file, it was found that this beneficiary was supposed to be discharged to an 03, so to skilled nursing facility level of care. In this review, the reviewer agreed with the coded DRG, so that was not in question. There was no change in the present on admission indicators that were needed to be made either. The inpatient admission was also looked at, and it was for an open reduction and internal fixation of a fracture of the right proximal humerus. And that was also found to be reasonable and necessary. So, and the CERT contractor in this case also received the complete inpatient record. So the only thing that was found to be in error was the discharge status disposition. And it was found in this one that the person actually did not go for custodial or supportive care in an intermediate care facility, but they actually went to a skilled nursing facility. And again, I'm going to bring this example back up in a little while, closer to the end of the presentation for today, because I want to revisit this and talk about some context clues of how we could maybe avoid this specific one. So as we move on to example 2. So in this example, the CERT medical review contractor, per that contractor, the discharge disposition in this claim happened to be 04, which was the assisted living. And that what was coded, that's what was coded by the facility. And it was found that it should have been an 03, so a skilled nursing facility in this case as well. So after, again, the CERT contractor reviewed all the submitted medical records and the common working file, the beneficiary was actually found to be discharged and admitted to a skilled nursing facility. So again, in this case, the CERT contractor agreed with the facility coded DRG. So there was no change on the present on admission indicators for this one as well. And the inpatient admission in this case was for a popliteal bypass artery bypass graft. And that was found to be reasonable and necessary as well. So again, the CERT contractor received the whole record. They didn't have any problem with the inpatient admission or how it was coded. The only thing they had issue with and found was this patient actually ended up at a skilled nursing facility instead of going to an assisted living. So we have a few more examples. Let's move on to the next slide and look at example 3. So in this review, the CERT medical review contractor looked at this claim and found that the discharge disposition on this one was 06, which was home health as coded by the facility, and it should have just been home. So after they reviewed the submitted medical record, the common working file, the beneficiary was actually discharged to the home. And so they agreed with the coded DRG. There was no change on the POA indicators in this one as well. The inpatient admission was for a right total knee. It was found to be reasonable and necessary. And the CERT contractor did receive all of the inpatient information. Now, why did this one occur? We don't know. We don't know if home health didn't start in this case within that 3 days, which could have been the actual problem. but per the way the common working file fell, per the review of the claim, this person's discharge disposition in this case should have just been 01 to home. So as we move on to the next slide, let's talk about this example 4. So in this one, the medical review contractor reviewed this chart, and this claim had a discharge disposition of 51, which was hospice facility. So that's what the discharging facility coded, was this person was supposed to be going to a hospice facility. What they found on review of the claims was it should have been 50 home hospice. So after they reviewed the submitted medical record, the common working file, they found that the discharge disposition was actually home. So they did agree in this case again with the facility coded DRG, and there was no change on the POA indicators, and the inpatient admission was reasonable and necessary, and they had all the information. So again, this one could have been, maybe there was not room at the receiving hospice facility. Maybe in this case, they found out that that their hospice inpatient benefit doesn't click in until that person's, transition to, demise is imminent. And so they would have been financially responsible. Who knows what the case may be in this case, but for whatever reason, they ended up taking this patient for home or for hospice services in the home instead of going to the facility. All right, and then on our final example, on the next slide, we have a discharge disposition of 01, which is home, which was coded by the facility, and it should have been in this case 51, so a hospice facility. So after review of the medical records and the intended discharge, was found to be listed as the patient was going home, the review of the common working file in this case supported that the actual discharge was to a hospice facility. So the facility coded DRG in this case would be incorrect. There's no change in the POA indicators. The inpatient admission was deemed reasonable and necessary in this case. But in this one, the discharge disposition was wrong. That means the discharging facility's DRG in this case was also incorrect. So there are some discharge disposition codes that do affect the amount of payment, like Aline said earlier, that the discharging facility and the receiving facility are eligible to receive. So let's move on and start with looking at some tips and tricks that could potentially help you avoid these errors. So on the next slide, communication here is key. I can't stress that enough. The most important people to make sure you are communicating with are your billers and coders. They're the ones that are putting the codes on the claim. So this communication to your billers and coders can come in a variety of different ways. Your billers and coders are responsible for looking at your documentation and generally your discharge summaries. Those are one of your key components of your documentation. And they code based on what is in the documentation. They can't make things up. They can't just code something because they're told if it's not captured in your documentation. Your billing and coding need to match your documentation. So sometimes you can say, oh, this was changed or this was updated or whatever the case may be, which means your documentation should be updated to reflect that as well. So again, discharge summaries, those are a key form of information that your billers and coders are probably looking at. Make sure everyone that is documenting in your patient chart, they're all clear on the discharge disposition of this patient. So your documentation is consistent with everyone. This includes the physician and the physician order for discharge, your nursing staff, highly your social workers and case managers, even your therapy staff, etc. This really helps. If you are clear and consistent across the board, this helps make it clear for your billers and coders that are looking across your documentation to easily find that consistent information throughout the chart and helping ensure that they are choosing the correct code at the time of the discharge. And that's based on everyone's knowledge. Now, like Aline and I both said, sometimes people go somewhere other than where everyone intended they were going. Everyone thought they were going here. But, you know, families do crazy things after they leave your facilities, and patients often end up somewhere else. And we're going to talk about that and those ended up somewhere else in a little bit coming up here. But another way to help in those situations where, like, a patient went somewhere other than the intended and documented disposition is through follow-up calls. Now, if your facility is one that is making post-discharge follow-up calls with the patients, this is your perfect opportunity to verify where they went. So if you have staff that are making post-discharge follow-up calls, consider asking additional questions. For instance, has home health started yet? Are you managing things in your home all right since discharge? Our records indicate that you discharged to your home without any additional resources or services. Is that still the case? Did you enter into hospice? Did your family member go somewhere other than their intended disposition? At the time you left our facility, we note that your family member was supposed to go home. Are they home? So these are just some things that you can think about and ask and start that conversation if you have someone that is making follow-up calls, or if you have clinical staff that, you know, call and make those check-in calls. Have them ask those few extra questions. Did the patient go somewhere else? And then if they did, how do we communicate that back to our billing staff? So another tip is to include additional information in the discharge paperwork that the nursing staff reviews with the patient upon discharge. And usually patient and family members, if the family members are present. So this can include information for your patient or caregiver to notify you as the discharging facility if that patient goes anywhere other than the intended discharge disposition. So this should also come with clear direction on who to contact via phone or email. So that information could be gone over with the nursing staff. We have facilities that say this works really well for them. It is part of the discharge notes. The nursing staff, when they go over the discharge instructions, go over it with the patient and family or caregivers and say, if they end up somewhere other than blank, where everyone's agreed that this patient is going when they leave your facility, or if they go here somewhere other than this in the next 3 days, notify us and let us know, either by phone or email, and have contact information right there available for them. Because if you just say, call our facility, the person answering the phone may not know where to send that patient. So you should have some internal policies, procedures worked out in your facility to help with this. Discharge summaries that go to other facilities, like a skilled nursing facility. You should also include some sort of statement to that receiving facility that your intended discharge disposition at the time of discharge was XYZ facility for skilled nursing facility services, or Part A skilled nursing facility services. And then have something in there that says, please notify the hospital if this is not the status the patient entered your services at. And then again, give clear direction on how they can contact that billing facility. Again, clear and concise communication is the key. Now, we did have, I told you I was going to go back. We had one pre-submitted question come in that stated that the case manager and the nurses at their facility state that when a patient is being transferred to a nursing facility, that they generally don't have knowledge of it if their care at the nursing facility will be skilled or intermediate. So they don't know, they said in this case, they don't know which discharge status code to choose. They also asked if there was a rule of thumb to use in these types of situations. And the answer to this is no, there's no rule of thumb. If the intent after discharge is a skilled nursing facility for skilled Part A services provided by nursing or clinical staff, those arrangements that the case manager or social worker, those are things that they should be working on prior to discharge. So they should be working on finding a skilled nursing facility, and they should know based on the information from the physician, other context clues like, did the patient have a 3-day qualifying hospital stay? Does this patient need to go to a nursing facility to receive skilled care? Is the receiving facility's intent to bring the patient in under a skilled service? Again, is there a physician order or notes, or does that information, say that this discharge is for skilled services? So those are some of the context clues that you can look at to say, yes, this person is going for a Part A skilled stay as opposed to an intermediate care facility. If, for instance, the patient did not even have a 3-day qualifying hospital stay, then they can't go to a Part A skilled service in a nursing facility, otherwise known as a SNF Part A stay. So in these cases, then they may be going for an intermediate level of care. So they may still be receiving skilled services, however, the care level might be intermediate. So again, look for those context clues. So as we get to the next slide, we're at the end of our presentation. I just want to point out that these are some really good resources for you to use. I will take a peek at the Q&As, and for those of you who can stay with us just a few minutes longer, I'll get those questions answered that are in the chat. But I do want to point out that the patient discharge status code at the bottom of that list where it says PDSC, that is information that we have on the WPS website. And we did just recently update it a little bit more to, give those a few additional bits of discharge status code information, but all of these are great resources. So as we move to the next slide, let me go and look at the questions that are submitted here really quick. If the home health does not start within 3 days, should the home health notify the discharging hospital? Ideally, yes. And again, this is one situation where you can update your discharge information that you are providing to that receiving facility, that receiving home health service, just to say, if it did not start by this day, please notify the hospital and give us that information. Is it wrong that you coded discharge to a home health facility? No, because that was the intended place that this person was supposed to go, to the best of your knowledge, to the best of everyone's knowledge. But if they didn't start within 3 days, we would hope that your home health or that receiving home health facility does notify you back and let you know that, so you can change your discharge disposition. Again, an easy thing to do is just to update some of those discharge forms that other facilities will want, and have a section that says, please notify us if something other than this happens. So the next question is, if a patient is to be discharged to skilled nursing facility, that is per the discharge plan, but the patient refuses to go and the patient instead goes home, would the discharge status be AMA against medical advice? And no, in this case, it would not. If you know this prior to discharge, if you know that the patient is not going to go to the skilled nursing facility, you should update your documentation, put that the patient is refusing to go to the skilled nursing facility and will be going home to the best of your knowledge. And then you discharge it with the code for home. Now, they may get to the home within 2 days, figure out this is not going to work, and the family drags them off to the skilled nursing facility anyways, and then they end up with an admission to a skilled nursing facility. We would hope that in this case that the skilled nursing facility again would notify you as a facility. Again, sometimes they don't. You don't know until that skilled nursing facility claim hits that you have to change the discharge status code for that patient. But again, in your question, no, in this case that the patient is just going home instead, even though that's not what you are advising, it's a discharge to the home. Okay, so that takes us to the end of our formal question and answer. Again, I appreciate you giving me the time to stay on for just a few extra minutes. So after this webinar is complete, those of you who logged into the webinar are going to receive an email. You're not going to get this email if you only called in by phone, and maybe not if you called in with or logged in with a mobile device. We found that sometimes you don't get this. This email is going to be your proof of attendance and have contact hours in it if you need those for continuing education. So if you didn't get it or you don't get it, it should be in your email box already, and you want it or you want a certificate of achievement, just email us. That email address, again, is in the chat, but it's also listed at the bottom of the screen here, and you're going to see it again on the next coming slide. So as we move on, if you find that you have an additional follow-up question that you just didn't think about while we were in session, go ahead and send those to Aline and I, and we'll get that sent out to everyone if we think it is something that everyone could benefit from, or we'll just respond to you via email. You have 7 days to send those questions to us at this email address that's listed on your screen. Put something like discharge status codes or discharge status in the subject line so we know it's for this event. If your question is something that's claim specific, unfortunately, Alina and I do not have access to those claims processing systems. Those questions, need to go through customer service. So please direct those there. We don't want you to send any PHI or PII, through an email. We don't want you to get in trouble, and we can't open any secure emails. So even if you say, well, I'm gonna send it secure, Alina and I can't open it and it will be deleted. So just so you know, if it's claim specific, go to customer service. All right, and then finally, as Aline mentioned at the beginning of this presentation, we want to hear from you. We value your opinion on how we did on this event. So the survey only takes a few moments to complete, and that's why we want to give you the opportunity and attach it into the chat. We did attach it once earlier. I'm going to attach that again, just so everyone has it if you were to need it. Otherwise, when the event closes, you're going to be redirected to a site. It's going to look like this bottom picture on the screen. It's not spam. It's just WebEx's way of saying you're going to an external site to take the survey. Again, the best part about the survey is it's your opportunity to tell us what else you want in the future, what additional types of education. So moving on, last but not least, or almost last, we want to hear from you. Please keep those surveys coming in. We're committing to making changes and improving your educational experience. Based on your survey comments, we've made some of these changes, like adding chapters to our YouTube, so you can just go out and click on that chapter that you want to re-review. We've also added training indicators to our live events, so you know if this training is clinical in nature, billing in nature, if it's UB04, if it is 1500, etc. So those are some of the changes that have come about. And then finally, on the last slide, on behalf of Alina and myself, as well as Medical Review, we want to not only thank you for your participation in today's event, but also for giving us a few extra minutes of your time. This concludes our webinar, and you may now disconnect.